Okay, thank you very much for joining us. My name is Tarisai Bere. I'm going to be the moderator for this meeting. I'm a clinical psychologist and a global mental health researcher working with OPHID and the Friendship Bench. We've invited a webinar, which is called Caring for the Carer, a webinar on the psychosocial that we are offering to all healthcare workers. So on our program, we have Dr. Rukudzo Mwamuka from Friendship Bench. We're hoping that Dr. is the Deputy Director of the Ministry of Health and Childcare Mental Health Department will join us. We have Dr. Machando from the World Health Organization. We have Ms. Sara Page-Mtongwiza from OPHID. She's the Chief of Party. We have Tapiwa, Mr. Tapiwa Takaona, our SIE manager from the Friendship Bench. So the program will start with an opening and introductions from Dr. Mwamuka. We just have 5 minutes for each speaker. I'll give more time to the question answer session so that everyone can contribute. Please ask those who want to speak to please raise their hand before they unmute their phones. Thank you very much for joining us. Over to you, Dr. Mwamuka.
Thank you, Tarisai, and a good afternoon to everyone. I'm delighted to be a part of this session today. On behalf of the Friendship Bench, we are really glad to be having everyone joining our webinar session today and being able just to talk and hear more from you and learn from you about this program that we've been having, which we are really hoping will be able to continue. I will give a brief background on the Friendship Bench for those who do not know the Friendship Bench. So the Friendship Bench is an organization which started from research and came up with the Friendship Bench model. But currently as an organization, our mission is to get people out of depression, and we envision having a Friendship Bench within walking distance for all. Our values are anchored in empathy, connection, and anchored in research. What we do at the Friendship Bench, what we would call the Friendship Bench model, is that we train lay health workers. When we say lay health workers, we mean the village health workers and any other community healthcare workers who are not professionals. We train them on problem-solving therapy. And after these trainings, they're able to provide these at primary care facilities or within their communities. The problem-solving therapy is done on a one-to-one basis, and someone can get up to about 6 sessions, although this varies depending on one's needs. When one has had at least 1 session on the Friendship Bench, they can then join what we call peer support. Sorry, Jenny, if you could kindly assist by muting everyone who's not speaking. Thank you. So after having at least 1 session on the problem-solving therapy, clients can then join a peer support group. This is led by clients themselves and facilitated by grandmothers. And we call it Seko Kubatana Tose. The primary goal of these support groups are so that clients can share their experiences on how they have managed to cope with depression. And the secondary outcome is that they are also able to do what are called income generation projects, which differ depending on each community. Some engage in crocheting, some do gardening, some do poultry rearing. And these are some of the services that we've been able to offer in the community, like I alluded to, the trainings, facilitating PST within facilities and online, creation of the Seko Kubatana Tose support groups, raising awareness about mental health, and adding to the field of mental health through our researches and also our youth program. In terms of the healthcare workers that are here today, there are various ways in which we have partners with healthcare workers in different fields through our trainings, through facilitating supervisions for the lay health workers, through the management of what we call red flags that are clients who are difficult for the grandmothers to actually manage, and also helping us through our mobilization and outreach activities. The various healthcare workers have also been a great help in linking us with health facilities and other organizations, and also complementing all of our programs work. Currently, as the Friendship Bench, we're in 7 provinces, namely Harare, Bulawayo, Midlands, Marsh East, Marsh West, Matabeleland North, and Mashingo. We are in 167 primary care facilities. And since 2016, when we're an organization, we've reached up to over 158,000 clients. And we measure the work that we do through the change in depression, where there's a significant drop of depressive symptoms, using our Shona symptom questionnaire, a screening tool that was validated here in Zimbabwe. Currently, some of the projects that we do or programs that we run is the traditional, or what we call the classic Friendship Bench, which is the one where care is provided for by the grandmothers. There is also the Youth Friendship Bench, where there is peer-to-peer counseling that is done by young people. And this is done physically in communities and facilities, universities, and also online. So they are able to, people are able to reach us through our open line number, and they will get a counselor. We also have the Workplace Wellbeing, which is a project that was spearheaded and started by our partner, the WHO, and we've continued with it since then, where we are increasing mental health awareness within the corporate space. And there's the COVID Go program, which we partnered with OPHID, which we are going to talk about in more detail today, which is the healthcare workers open line. And when we talk about healthcare workers, we are not just talking about nurses or doctors, but everyone who works in the healthcare space. We also have research projects that are currently ongoing, the Succeed Project and the Youth at Mind. Some of our partners include the Ministry of Health, with whom we have a memorandum of understanding, various city health departments in the various provinces, the World Health Organization, which has also recognized us as a partner and has recognized Friendship Bench as a program that needs to be scaled up in the WHO Special Initiative for Mental Health 2019 to 2023. We also have partnered with various non-governmental organizations, such as OPHID, Africaid, SESHA, Pangea, and many other organizations that I might not have mentioned. And we also have partnerships through our Youth Friendship Bench within various universities, such as MSU and Great Zimbabwe University, the University of Zimbabwe, and NAST. And with these universities, we have bilateral agreements, which has enabled their interns in the social sciences field to come and do internship at the Friendship Bench. I know Tarisai is looking at the time and is almost counting that my 5 minutes is up, but I'm actually done. And that's a brief about the Friendship Bench. You're able to get more details about what we do and how we can partner and how you can contribute to the work that we do through all those various channels, our website, and our social media handles. And as I come to a close, I'm just really excited that we have managed to transition from our classic or traditional Friendship Bench, where we were having the lay health workers providing care to clients, but we have actually been able to learn and be able to adapt and come up with these project for healthcare workers that we are talking about today. And without any further ado, I will allow Tarisai to introduce the next speaker, and we can move on to the depth of what we really did with the project, and we get to the feedback that the rest of you guys will be able to learn from you. Thank you very much.
Thank you so much, Dr. Rukudzo. Next on our program is Dr. Mawunganize. I'm not sure if she's joined yet. Dr. Mawunganize, are you on?
Sorry, Dr. Mawunganize is having network challenges. If she manages to join, we'll let you know.
Okay, that's fine. So while we're waiting for Dr. Mawunganize, I think I'll just go ahead and talk about mental health and maybe introduce the program that we are presenting today. I'll share my slides. Okay, before I go on, I'd just like to acknowledge USAID, the Friendship Bench, and OPHID, who are the sponsors for this program that is meant for us as healthcare workers. And thank you very much for allowing us to have this program, which has proved to be very helpful for a lot of healthcare workers. I want to talk a bit about mental health, but not dwell into it because we're really here to introduce the program and learn a bit more about the actual open line. So from talking to some of you, we've been going around the country and talking to some of you about mental health. And the feeling that I got is that we still view mental health as something that happens to other people and not us. But as healthcare workers, we go through a lot. And in the past 2 years, we've been going through a lot, taking care of other people during the COVID pandemic. So I just wanted to define mental health for us to normalize mental health. And when we talk about mental health, bringing you this program, you appreciate what we really are talking about. So according to the World Health Organization, mental health is a state of well-being in which each individual realizes his or her own abilities, can cope with normal stresses of life, can work productively and fruitfully, and is able to contribute to his or her community. So this is what we really are focusing on when we talk about mental health for the healthcare workers. We're not accusing you guys of having psychosis or having depression and other mental illnesses that come to mind as we start talking about mental health. But just acknowledging that we've been going through a lot, and maybe the way that we cope, the way that we do things, the way that we work has been disturbed. So physical health sometimes and forget about our mental health. And according to the World Health Organization, for you to be able to be termed healthy, you need to have a complete physical, mental, and social well-being. So we really don't want to forget the mental aspect of our health when we talk about health. And as the people who are in the forefront dealing with health, we need to be aware of what we really should be talking about as we help others. So in the last 2 years, we all know that we've been going through the pandemic, and some of the things that you had to deal with as healthcare workers in the first wave were really based on fear and not exactly mental illnesses per se, because I think we had it easier in the first wave. We didn't have many cases of COVID, and we were not overwhelmed compared to other countries. But we also had fears that we had to deal with. Fear of falling ill and dying, because we were working without enough PPE sometimes. We were scared of being socially isolated. We were feeling powerless in protecting ourselves, in protecting our loved ones. So we went through quite a lot of fear, and sometimes fear then, leads to anxiety and other mental health problems. In the second wave and in the third wave, as well as the fourth wave, we started seeing a lot more people dying. And sometimes, we couldn't help them in the way that we wanted to help them because we didn't have enough of the things that we needed to help them. For example, you could watch a patient dying because there was no oxygen for them. So we were exposed to quite a lot of trauma. We started losing our colleagues. You could go to work and you hear that Dr. So-and-so has passed away because of COVID. And it became a bit more real for us and very close to home. We were grieving loved ones, we were grieving our friends, we were grieving, family members. But also with this came more work in such a way that you had longer hours, which brought in sometimes burnout
It looks like Tarisai has lost her connection, and we might
I'm back. Sorry, Dr. Rukudzo.
Okay.
All right.
Please go ahead, Tarisai.
Okay, so I'm not sure where you lost me, but I was just going to conclude and say that, you know, as mental health practitioners, we've come together with the Friendship Bench to offer you support, and this support is free, supported by OPHID and USAID. So I'll give this time to Sara, who's going to take us through what the open line is and explain a bit more about the support that we're getting from OPHID. Over to you, Sara.
Afternoon, everyone.
Afternoon.
Good afternoon.
Thank you, everyone, and thank you for having us here. We're so excited to be part of this webinar. We are talking today about the open line and the caring for carers. Dr. Bere talked a bit about why we have started this project. And with the support from USAID, we have had the opportunity to work on providing a platform for healthcare workers to access mental health support. And I have the honor of talking a little bit more about it. Next slide. So just to tell you a little bit about OPHID, hopefully you know the organization, but OPHID stands for Organization for Public Health Interventions and Development. It's a local organization that develops innovative approaches and strategies to strengthen the quality of HIV prevention, care, and treatment. And we place a strong focus on family-centered approaches to healthcare and we provide enhanced access for communities in maternal, neonatal, and child health, as well as sexual and reproductive health. Next slide. So just a bit about the COVID Go program. So Zimbabwe recorded its first COVID-19 case on March 20th of 2020. I'm sure everyone remembers. And in response, Zimbabwe developed a national preparedness response to reduce the morbidity and mortality resulting from COVID-19. And all of us have gone through a tremendous amount of anxiety and changes with the restrictions, with the pandemic, learning how to cope with the pandemic. Healthcare workers, however, were at the forefront of the response, and the COVID epidemic, of course, layered on current stresses and additional stress for healthcare workers about the uncertainty regarding the COVID outbreak and whether it could be put under control. Healthcare workers also talked about the effect it would have of being at the front line and the impact on their families. And I think Dr. Bere talked through some of the concerns that healthcare workers had raised. We know evidence across the world is showing that COVID-19 epidemic has impacted on the mental health and the well-being of healthcare workers. Next slide. So the COVID Go program was created as a one-year program supported with funds from PEPFAR, USAID, and ARPA. And the COVID Go program had 4 objectives. And we're going to talk about one here, which is about the provision of mental health services for healthcare workers. But the program was slightly broader in the sense that it also helped the Ministry of Health to scale up vaccination and contact tracing. But in particular related to the mental health work, the goal was to provide a psychological intervention to healthcare workers, recognizing that they're at the front line, to look at mental health sensitization, screening of common mental health disorders, including depression, anxiety, and suicide, providing self-help materials, and establishing a dedicated platform for free, anonymous, confidential mental health counseling and referral for healthcare workers. Next slide. So this is what we set out to do, and this is what we have achieved. And we have developed materials through the experience of the Friendship Bench, drawing on their over a decade worth of experience in designing self-care materials and helping to put together a curriculum to deal with mental health and messaging around COVID-19. We established an open line for healthcare workers, and the services are available in English, Shona, and Ndebele. The open line was launched in April 2020, and it was intended to be an anonymous, free, confidential counseling service. Recognizing that healthcare workers may not be comfortable to open up to peers, may not be comfortable to open up to walk into a clinic, for example, but to have access through a mobile phone number or through a web base to be able to access information to talk to someone how they're feeling. The program enlisted decentralized clinical psychologists who also conducted facility-based sensitization meetings. And this was particularly important to mobilize and create awareness around the open line and make sure that people knew it was available. Through the program, we've been supporting upskilling of existing mental health professionals to provide dedicated support to healthcare workers, and through the platform, creating a referral pathway when someone calls the open line. If there's need for further referral, it is done through the Friendship Bench, through the open line, and to establish clinical psychologists. It has been an exciting program. We are hoping it is going to continue, and we're looking forward to having more and more healthcare workers aware and using the open line service. Next slide. So thank you very much for inviting us to be part of this webinar today. And I do hope that all who are registered as part of the webinar will share the information, highlight this service to healthcare workers because it is there for them. We know sometimes it's hard for professionals, in particular healthcare professionals, to ask for help, but this is a platform that is there and available for healthcare workers. Thank you very much.
Thank you, Sara. Thank you so much. I'd like to encourage people to please register in the link that's provided in the chat box. Please use that link to register. Thank you.
There's a hand,
next on our program.
Before you move to the next speaker, I think we've got a couple of questions. There's a hand from Dr. Nyakabao.
Okay.
Thank you. Thank you very much for this initiative and for the presentation. I would like to ask that, yes, online webinars are very good because accessibility, and also during the COVID era, it was the most reasonable way to reach out to healthcare workers. I understand you are collaborating with the Friendship Bench. Do we have Friendship Benches at, say, the major hospitals, for example, so that at least if one would like maybe a one-on-one contact, it's easier?
Okay, thank you for that question, Dr. Nyakabao. We are going to give 30 minutes at the end after the next presentation for us to brainstorm. So this is some of the feedback that we'd like to hear from you. If we are to continue with this program, how exactly would you like us to bring in the services? So please hold on to that thought. I'll come back to you after the next presenter. Thank you so much.
And
Tapiwa, over to you.
Thank you, Tari. Good afternoon, colleagues. So I'm just going to do a presentation. Tari, please confirm that you can hear me loud and clear.
Yes, I can hear you, Tapiwa. Please go ahead.
Thank you. So I'm just going to do a bit of a presentation on the outcomes, the results, and feedback from program participants thus far. That is, as we interacted and implemented the program. So yeah, so the slide. So to date, we've managed to reach out from program inception to date. We've managed to reach out to 2,326 healthcare workers through screening for depression and anxiety. And this was done through the SSQ-14 questionnaire. We've also managed to reach out to 1,808 self-care. We've managed to distribute 1,808 self-care materials to healthcare workers as well. And of those, of the overall reach of our healthcare workers, we've managed to have 144 successfully receiving problem-solving therapy through the open line platform. And also, we've managed to engage in and around the 6 provinces that we're implementing 55 health facilities. This is the facilities where we're engaging for active engagement of COVID-Go interventions, the sensitization, the screening, and the distribution of the self-care materials. So that's the reach to date for the COVID-Go intervention as of this week. And then in terms of just trying to do a bit of descriptive on those healthcare workers that we've managed to reach out to. In terms of gender, females, we've of the reach 1,558 were female, which constitute about 67%, and then 449 were male, which constitute about 19.3%. And then of course there was the unknown bit for various reasons. We didn't manage to gather the gender data on about 319 healthcare workers, which is about 13.7%. And then the age bands in terms of which the 18 to 24 age band, we reached out to about 209 healthcare workers, which is about 9%. And then 25 to 34, under that age band, we managed to reach out to about 465, which constitute about 20%. Then 35 to 44 age band, we reached out to about 698, which was the highest in terms of reach for the age band, which is about 30%. And then 44 plus, we managed to reach out to about 658, which is about 28%. And then there was the unknown bit as well, which was 302 healthcare workers, which constitute about 13%. And then in terms of COVID-Go infection, those that during screening or engagement, those that answered yes to being to having been infected and affected by COVID, 1,233 answered to the affirmative, which consisted about 53%, and 1,093 stated that they did not contract COVID during the various waves that the pandemic rolled out within the various provinces of Zimbabwe. So yeah, that's it in terms of the demographics. And then reached by health worker profession, 6% did not manage to state where and what profession they were, but 1.1% were psychologists, and the physical therapist about 0.2%, pharmacist 0.6%, and the nurse aid they were about 16.1%, which is quite significant. But the majority of the healthcare workers that managed to interact with the project were about 41%. These were the nurses within the various health facilities that the project was being implemented. And then the laboratory technicians and scientists constitute about 0.8% of the healthcare professions that were reached. And then health support staff, the cleaners, the general hands and the like, they constitute about 12.3%. Then the health promoter constitute about 7.6%. And then the finance, accounting, and admin staff within the health facilities, they constitute about 6.8%. And then the community health workers, the village health workers, they constitute about 7.4%. These were mainly from the various districts that are operating within the rural space. The Zaka, the Gutus, and the Shurugwis in the Midlands as well. And yeah, so in terms of screening outcomes through the SSQ-14 questionnaire, against a program target of 2,000, we've managed to reach 2,326. And of those that were screened, 1,784 were screened under the SSQ-14 to have an SSQ-14 score of 7 and below. And then 392, they were screened to have an SSQ-14 score of 8 plus. And then those that were red flags, they answered positive to question number 5 and 11, which is the suicidal ideation and also hallucinations. The 150 healthcare workers that were screened to be red flags. Yeah, so that's it. And then now I'll get into the challenges that we've faced thus far in terms of implementation and trying to engage the healthcare professionals as well in and around the health facilities we're working. Yeah, so healthcare workers are mainly presented with psychosocial stressors, and then busy schedules of the healthcare workers. Your time factor still plays a major role in hindering healthcare workers from seeking out the COVID mental health counseling sessions, where they would cite that they're just too busy to actually attend a PST session. Maybe they presented themselves to have been screened for depression, at high risk. But if they're then invited for a counseling session, a healthcare worker would probably cite the time factor in terms of I'm too busy to actually then be able to actually attend the PST session with a counselor or a clinical psychologist. And then also the healthcare workers failure to deal, sentiments are that they feel they can handle issues by themselves. They are not allowing themselves to be cared for. I suppose they always see themselves as the carer, but I suppose that was a major challenge as well. And then online modality, as we interacted when we moved around the health facilities, when we were interacting with the healthcare professionals and the matrons and then the powers that be within these facilities, they came out a strong a sentiment on strong preference for face-to-face sessions. Key informants said that they needed to cry and relieve themselves of issues. So over the modality that we were running under the COVID Go program, which is the open line. There was a strong preference for, having a physical bench and having a face-to-face session with a counselor or a clinical psychologist. And then healthcare workers in rural settings, remote areas face connectivity issues, hence at times cannot attend counseling sessions. If it's online, and if it's a healthcare worker, or if it's a nurse or nurse aide or a support staff in a rural setting, they cannot then access the services because of connectivity issues. It's low bandwidth areas, so hence that was cited as a strong a challenge as well. And then awareness of the program was suppressed in the health institutions due to resource limitations. I suppose the sentiment was, with the program implementers, was that more could have been done in and around the health facilities to bring awareness on the services and products that the program is offering to the various, clientele that we're targeting, which is the healthcare clientele or healthcare workers. And then in terms of lessons and recommendations, I suppose there is need for dedicated mental health services for healthcare workers, which should be intensified, during pandemics. If COVID go or any other pandemic, I suppose there needs to be a dedicated budget, and I suppose services that are targeting the healthcare professionals during the peak of such pandemics, I suppose. And then there is also need to, think outside the box, have innovative ways to actually, have mental health awareness for healthcare workers. It can be through apps, social media, or whichever way. But, I suppose there's need to think around it and brainstorm on which other innovative ways can we then, upscale, or bring mental health awareness and services to the healthcare professionals. And there's also need to address social stressors, particularly financial constraints. I suppose this came out as a strong, problem or a strong pointer for, depression or anxiety among healthcare professionals. I suppose it's a recurring major, theme within the counseling sessions or engagements that are being done with the healthcare professionals. There's also for further research, I suppose, in terms of understanding barriers to seeking mental health services by the health professionals. Some nasty feedback. Messi, can you please? Yeah. Thank you. So in terms of further research, there's need to gather evidence around, the barriers to seeking mental health services by healthcare professionals, and then I suppose offer a treatment protocol for that particular cohort of professionals in terms of how then can we further the mental health services for that particular healthcare workers. And then there's also the psychosocial interventions that are acceptable and feasible for healthcare workers as well. And there's also need to create safe spaces for healthcare workers to engage in services available to them. Yeah. And then the IC material, that the flyers, posters, and self-care journals, there was the preferred language was English amongst the healthcare workers, as they said it. it was easier to understand and take in. It was the program, did adapt and to various vernacular languages, but the strong sentiment was the majority of the healthcare professionals, they prefer English, I suppose, as the mode of communication through their EC material. And then it was also cited as we went around the health facilities that it's necessary to have a good mixture of vernacular language material across the country as the health professionals are moved across ethnic lines or language dividers. They are posted their respective employer. The assumption that if you're in Machibelela, you then need a Bere focused IC material. It was debunked that there's need then to actually have a good mixture, because we might have healthcare workers that speak other vernacular languages within those areas. And then it's critical to utilize the health facility structures for sensitizations. They exist within the institutions, health promoters that can be used to raise awareness around issues to do with mental health. So the program can then need to tap into these structures for an effective, awareness raising and, just energizing for health, mental health services amongst the healthcare professionals. And then it's also critical for awareness campaigns and to destigmatize mental health amongst healthcare professionals as well. Yeah, so there's a lot of stigma, I suppose, that is still prevailing amongst the healthcare professionals. Yeah, thank you. That's my presentation. Thank you. Over to you, Tara.
Thank you, Tapiwa. So while we wait for our next speakers, I'll allow 5 questions. You can raise your hand or type on the chat.
Hi, Tarisai. I've noted 4 questions while those were raising their hands for other questions.
Okay.
There is a question, I think, that was already shared by Dr. Nyakabao. There's also another question in the chat on when does the program plan to provide care for those who are in training. And then there's a third question about relationship. Did you find any relationship with the length of service or age? There was also another comment and question on whether the findings have been shared with HSB or the respective human resources department. And I think finally there's another one here from Edwin Sivanda, which says, what was the perception on confidentiality? So maybe we can distribute the questions around. Tapiwa, would you like to take some of the questions?
Yeah, let me see which one I can take. Maybe I can take the one on I don't think the findings are yet to be disseminated. There's one from Edwin with findings shared with the HSB or other HR people. I stand to be corrected, but I think this is the first platform where we have managed to actually have an engagement outside the program in regards to sharing our findings and information. Yeah, I don't think we've managed to do that yet, but it's something that we might look into. Yeah.
And there's a question about whether the findings, were there any relationship with length of service and age? If you actually that association at all?
We hadn't really explored that. We hadn't really inferred any across the variables in terms of maybe patients presenting with anxiety and depression to age and length of service. We hadn't really explored that, but it's something that we can look into.
I can take, I think, some of the question that Dr. Nyakabao raised about a physical bench. I think it's a very valid question. And I think from what Tapiwa shared on some of the reasons why people didn't want to take up sessions was there was a preference for physical sessions for some people, but at the same time, there was a strong fear of stigma, of being known to be the one who has gone to sit down on the bench. So I think today's gathering, we do have over 200 healthcare workers here. And I think when we get into the discussion, it would be good to know which one of those factors is the bigger factor because it seems the fear and the stigma of not to have sought out help stops people from actually reaching out. And that was the idea behind the program, to say, maybe if we used an online platform or a virtual platform, which is anonymous, that will help with confidentiality, and that will help healthcare workers to reach out more, because they actually, we don't know who you are. You could tell us your name is Brian, and we don't know it is or even your profession, and that could be helpful to just break down that barrier of stigma. So yes, we do have benches around the country in the 167 facilities that we have spread around. The main reason why we don't have benches on tertiary facilities is because those services are already available. Our main objective as the Friendship Bench is to provide low-cost psychosocial support through our lay health workers or community health workers. Therefore, the benches that are scattered are mostly in the community services. If we look at facilities such as Parirenyatwa, we already have the annex at Tarara Hospital. We do have mental health nurses there and psychiatrists, in as much as they may be limited. So that could be a reason why we do not have physical benches spread out on those places. On the issue of plan to cover those who are in training, I think that's something that we have also taken note of, that we do have nurses in there affected by both the effects of being a healthcare worker and also being a trainee. And I think it would be also up to our funders, because sometimes we're limited, and it's great that we have Sara Page here. She'll be able to at least maybe respond to that on whether those people can be included in the project now or later if the project continues. I think we have answered all the questions. Maybe Tarisai, if there are any other questions.
Yes, do we have any other questions? I see Dr. Nyakabao, your hand is up. Do you want to respond or?
Thank you very much. I actually want to add something on in terms of the possibility of stigma on non-usage of resources at particular institutions. The problem is that, there is the fear that the people that I know are more likely to perhaps talk about my issues. Whereas if you have a friendship bench with people whom I don't know, I am in a better position to open up and be able to speak out and behave in whatever way I behave, because they don't know me.
Okay, thank you for that, Dr. Nyakabao. I think very valid points as well. Issues of stigma are real, and this is why I think we've started with healthcare workers. If we're able to provide psychoeducation around mental health, I think it will ease the fear of people talking about your condition or maybe your stressors. I'm encouraging each and everyone on the call to start learning more about mental health, because from what we are seeing, we do tend to separate ourselves from mental health issues, and it's difficult for people to then seek help if there's so much stigma even coming from us as healthcare workers. Thank you very much for that. Do we have any other comments at this point?
I also wanted to add the fact that, obviously, key opinion leaders, if you get key opinion leaders making use of the resources, people that they can identify with, to say, Dr. Nyakabao was at the friendship bench, some people may feel, better to be able to use the resources as well.
Okay, thank you.
There's another question, Tari, in the chat. Not an easy question, but the question's asked about whether with the program we've been able to save any healthcare workers from suicide.
Okay, all right, so that really comes with confidentiality as well. I would say that maybe we can't really give figures there, and the things that we then do in sessions. They've been red flags. Yes, our SSQ 14 has the suicide question, and it asks about suicide ideation. If someone has a plan or have high risk of committing suicide, then we do provide intervention. So maybe just to mention, the way that the program goes is that when you use the online platform, you are talking to a mental health supporter, who then checks for all of these things. If they feel that a person needs a clinical psychologist or a psychiatrist, or needs to be referred for further evaluation and management, then there is space for that. So yes, we have had red flags and we've dealt with some.
Mr. Samkanga has his hand up, Tarisai.
Please go ahead, Mr. Samkange.
Good morning. Thank you very much for the program. It's absolutely an essential service. Someone has asked about that problems with medical students may well start during their medical school training days. Has any consideration been taken towards this? The answer is yes. When Mr. Harry was chairman of the Professions Council, he instituted the registration of all medical students with their council, MDPCZ, and equally recommended that the Nurses Council should register their trainee nurses. The reason behind that recommendation and why MDPCZ registers the students is so that these things can be captured early and dealt with. If the teachers in any of the medical schools were to that there is a problem with a medical student, or if any medical student could note that there is a problem with their colleague, all they have to do is to notify the MDPCZ. They have a special committee that deals with mental health issues. This committee will then call this person confidentially and assist them without going through the disciplinary process. This facility was created so that things could be dealt with at an early stage and before people even get to graduation and therefore joining the profession when they're having mental health issues. So if any one of us feel that there is a medical student there who has a problem, they should notify MDPCZ, which will help the student rather than punish the student. The problem we have with a lot of us is that we see problems, we note them, we even talk to each other about them, we mention it to each other in corridors, but we don't actually alert the people who have the capacity to help. And I'm glad they have introduced a second service now, apart from the MDPCZ service, which is actually the Friendship Bench service. Thank you.
Thank you very much for that response. Do we have any more questions? If not, I'm going to give this time to Mr. Musoro from the Ministry of Health, our Mental Health Department, to just say a few words. Mr. Musoro, thank you for joining us.
Thank you very much, Tari. Thank you very much, team, Friendship Bench team. Thank you for all this initiative you guys have done. And we are so excited about the direction mental health is taking in our country. And I hope the sessions are going on very well. Unfortunately, I joined later and didn't get the initial part. Dr. Mwanganidze should have joined, but where she is, she's actually struggling with internet connections. However, from where I've joined, from the time that I joined, I think so much has been said, and it's so exciting. We are happy. Thank you very much for this initiative, Tari. Over.
Thank you, Mr. Musoro. Okay, so I think we've come to our question and answer session. So we'd asked some of you to use the line and the online platform prior to this meeting. Would like to hear your feedback and would also just want to use this opportunity to think about your needs as healthcare workers if we are to continue with this program, what would be useful for you? And also just think around how you would like us to conduct the session. So we've talked about online versus one-on-one. What would you prefer? And if there are any other concerns, I think this is the right time for us to discuss all of that, so that as we continue to bring the service to you, we're bringing something that you can actually utilize and you're happy with. So maybe just to say, we started this program in March, and the uptake is not been as high as we expected, given the the evidence coming from other countries that healthcare workers were really affected by the pandemic. So we'd also like to just understand from you guys what the problem would be. Why would you not seek help? And this might be confidential, but let's just make it a general discussion. So for the next few minutes, we'd really want to hear from you. I'll maybe start with those who've used the platform. What were your experiences and what would you suggest that we improve on? So I'll ask Jean and Dr. Mwamuka to just help me with the hands and the questions on the chat.
Sure, Tarisai. If Jean can also be able to put up the number for those who have not seen the flyer or who have not reached out to the service as well. So while people think, it seems there are two questions that I have seen in the chat. One of the questions is, how accessible is the healthcare workers caring for carer program for interns that are in social sciences? How much of an understanding is there when it comes to social sciences as compared to health sciences? This is with regards to their mental health. Then the second question is from Bere, which says, are there dedicated psychologists and psychiatrists available for those that are deemed to have red flag? Is there financial assistance for them? So I can start with the first question. Sorry, if Sharon can mute your mic, please. Thank you. So the first question about interns, like I said in my earlier presentation, is the Friendship Bench. We do have the lay health workers who provide care, but through some of the research that we did, we saw the need to start what's called the Youth Friendship Bench. So the Youth Friendship Bench partners with universities. We do have a partnership with NAST. We do have a partnership with MSU, Great Zimbabwe University, and looking forward to having our written agreement with the University of Zimbabwe. And in all these universities, our peer counselors are available to speak to any student, regardless of which program they attend. But mostly the service is available nationwide, because our open line number is also there for those who want to reach out via WhatsApp, text sessions, or even via a call. And then on the second question about dedicated psychologists, yes, in as much as our primary work is based on training of non-professionals, for this particular project, we had 5 registered clinical psychologists who were attending to all the red flags that were there. So yes, there are dedicated clinical psychologists who are available for physical and online sessions. I'm not sure about the question. Maybe Tatenda can clarify about the financial assistance, whether is it for the providers or for the healthcare workers. I don't know, Tatenda, would you like to clarify? Okay. There is also a comment from Majita Machinga. Majita says that, thank you so much for insights. We did a similar study at 3 hospitals in Mutare, and from the results, we came up with a emotional support protocol, and we have started a wellness program. We have a safe space where healthcare workers go for support, and it's working. Thanks a lot. Our research is already published and you can access it. Thank you very much, Majita. If you could kindly share maybe a link to the resource so that everybody can also be able to read through it, and we can also learn from your findings, or if you're able to share from your findings what the preference you found the healthcare workers wanted, which can also help to perfect the current program. So after Tatenda, if Majita is able to, you can also give your comment. Tatenda, please go ahead.
How does Dove care for underarms after shaving? Hello? Hello?
Yes, we can hear you, Tatenda.
Okay. Yes.
Your volume is very low, though.
Hello. Okay. Can you hear me now?
You can go ahead.
Okay. I was referring to financial assistance for the patients. Do they see the psychologist for free? Are they referred to, or are they referred to the psychologist and they have to?
Yeah, right. I hope I heard your question well, Tatenda. There's someone who's got their mic on. Esther Magune, please switch off your mic. Yes, all the services that we're talking about are free of charge.
Okay, thank you.
Esther, may you kindly switch off your mic? There was a comment from Majita. Majita, would you like to go on with your comment? Okay, I think Majita is not able to. There is Samantha. Samantha, would you like to speak to your suggestion in the comment? Samantha Gono. Samantha wrote in the comment section that it's not a question, but a suggestion. I think mental health for the carer should be added to the modules for students in the different health programs so that they are aware of the resources that are available to them. I know for medicine, there's, sorry, I seem to be losing the chart. It says that I know for medicine, there's psychiatry, but this is more of teaching the students how to take care of patients. They also need to be taught how to take care of their mental health so that they are better able to take care of patients. And this could be maybe added to the modules. So I think we do have lecturers within the university, people like Tarisai, people like Dr. Nyakabau, Mr. Sam Kang, and I think they're taking note of this. But I do know that there is a mentorship program within, particularly to the medical school. It's only that sometimes students are the ones who do not take the initiative of actually pursuing that. But I think mentorship programs are there. When you speak to your mentor can always be there to guide you and give you direction and also point you towards any resources that are available to you. There's a question from Tapiwa Muhamba. The question says, what measures towards alcohol, drugs, and other substance abuse is this program offering to healthcare workers, since our main challenge is the lack of insight towards them, I think. Currently, the program, most of the, I think from Tapiwa's presentation in terms of findings, the main reasons why people presented were mostly psychosocial stressors, things to do with money, mostly financial constraints, relationship issues, and the like. And currently, on the people that reached out, there wasn't many issues around substance, although we do know that this is one of the main things that healthcare workers suffer from. And we do not have any drug rehabilitation facility or program, although we support clients through their process of rehabilitation or address stressors around that, which might be the background of their problem, because as you know, alcohol and drug abuse are usually a symptom of an underlying problem. So most of the times we then refer them to other facilities that are able to do so.
And yeah, maybe just to add on to that, Dr. Rukudzo, just to say that the intervention is problem-solving therapy. So if some of these issues do come up during the session, then a person is able to be referred where they can get the help that maybe we are not able to provide on this program. So it's just looking out at what the problem is and coming up with some solutions that will be helpful. Okay, all right, I think we don't have any more questions. Mr. Msoro is...
sorry, Tarisai.
Yeah.
There's still a comment from Audrey in the chat.
Okay.
Audrey's comment is de-rolling. I think for healthcare workers is difficult because the work doesn't just end at the workplace. People seek advice from healthcare workers even after hours. You are still the nurse in the family or neighborhood or counselor in the area. De-rolling or seeking help and acknowledging a weak moment is difficult when expected to be strong constantly.
Okay, I think this is what we are acknowledging, that as healthcare workers, we have much more work to do even after hours, but we are encouraging you to take care of yourself first, because what the research is showing is that because you take on a bit too much, sometimes the care that you then give to your patients is not as it should. So we're acknowledging that, you know, having too much to do, or, you know, working longer hours, being the nurse at home, being the doctor at home, is also affecting your mental health. You come first. So if you feel like you're taking on a little more than you can handle, it's okay for you to say no. And I know that also comes with difficulties. Saying no is not easy. There are ways that we can teach you on how you can say no and not sound rude. Okay, so this is part of the intervention. And if you want to learn more about self-care and, you know, de-rolling and saying no, then please use the service. I think Jean has shared the phone number on the chat, but we'll do that again as soon, so that you also have the line. And if you want to use the line straight away after this session, you can go ahead.
Hello. Hello.
Yes, Majita.
Yes, thank you so much. Sorry, I was muted. Yeah, thank you for a very insightful research, because it really helps us to make sure that our healthcare workers are well taken care of, so that they can also take care of our people. We affirm the importance of space for healthcare workers, also of the available services, so that they are able to go.
Sorry, Majita, we can't hear you. I think Mashita has a bad connection. I don't know if anyone managed to hear her. There's a comment I think I had skipped from Kudakwashe Musanu. I don't know if Kudakwashe would like to speak more on this and what his suggestion would be. He talked about what measures towards trauma does the program offer to healthcare workers. We do recognize that not every therapy is suited for every condition. Since the program is centered around problem-solving therapy, mostly addressing things like depression and anxiety and whatever stressors facing their life, it is not the best suited for things like trauma. A more trauma-focused therapy would be more appropriate, which sometimes people do share during their sessions. And having had the privilege of having registered clinical psychologists, they are able to assess for these traumas and be able to help. So I think in that aspect, it is covered. Maybe the Kwashe, you have a suggestion towards that, if you're able to speak that is. If Kudakwashe is not able to speak, I think I'll read some of the last two comments, which are more of encouraging comments from Tobekile and Ndlovu. As healthcare workers, let's learn to take care of each other and not pull each other down. Mental health is there and a lot of other issues, including drug abuse. As leaders, let's be vigilant and assess issues, especially our colleagues, and be a shoulder to lean on, but not to add more taunt on others' problems. So I think Tobekile is also talking about supporting each other. And I think Rita Tlotlo is just commending the presenters on their good presentations and a good discussion from the rest of the team. Mr. Zirima is saying this is really helpful. Healthcare workers need to realize the importance of taking care of yourself first. You cannot pour from an empty cup. That's a very good comment there. Over to you, Tarisai.
I think there's one more person who's speaking. I can't see from this end.
It's Kudakwashe. Kudakwashe, you can go ahead.
Okay,
Hello,
so please make sure that you register in the link provided so that we'll be able to reimburse your data, and also for allies to be able to give you your 2 points for joining the call. We encourage you to continue sharing your ideas. If we were to continue with this service, how would you like it, online or face-to-face? And maybe give your reasons.
Maybe you might want to ask the question again so that people put in the chat, Tarisai.
Okay, so if we were to continue with this service for the healthcare workers, would you prefer that we do it online? If we're going to do it online, would you prefer WhatsApp messages or someone calling you? And then the second question is, would you prefer one-on-one? And if so, please give your reasons. Okay, so Olga says online, please. Zoom is important. Thank you for that, Olga. Do we have any other comments? Any in really fast, Dr.
Yeah, they're coming in fast. I think there's online, most people can attend. Someone suggests a hybrid approach depending on client's preference. I think Memory is talking on presentations to be online. And yeah, mostly online. I'm not sure if there is no mixing up of the question, because Tarisai's question is talking about the actual sessions and not just the sharing of our project findings. So most people are talking about online, because I think Remembrance says it's because you can attend anytime from anywhere. Sharon talks about, Dr. Sharon Shingara is talking about a hybrid approach as well. Someone talks about Zoom. Yeah, so I think there is a lot towards a hybrid approach. The reason for Rudadiso's preference for face-to-face is because it's more engaged. And Dr. Moore says we spend a lot of busy time addressing patients' problems. There's a need for human contact. So I think that's a preference for physical. There are others who are still talking about online. The hybrid approach is also being favored.
Okay. All right. Thank you very much for your responses. We've noted them.
So they can keep them coming while we do the concluding presentation.
Yes. Is Dr. Mwamuka on now?
No.
Okay. All right. Okay. So the other thing that I wanted to just mention is that right now we have 5 dedicated clinical psychologists for this program. We're going to continue this month and next month. And then we'll update you on any future plans. So please make sure that you use the service. This is free, and right now it's online, but if you prefer to have group sessions for your organization, you can invite us to come. Okay. All right, I don't see any other comments or any hands, Dr. Rukudzo. So I think we can conclude. Unfortunately, Dr. Mwamuka and Dr. Machando from the ministry and WHO were not able to join us. They were going to give us recommendations and a way forward. The reason why we have been working with them is for sustainability. So we don't want to then just drop this project after a certain period of time because we can't fund it anymore. So hopefully the ministry and the WHO will be able to help us continue so that the service is there forever. That's my wish. Yeah, thank you very much for joining us. If there are any other burning questions or comments, you can raise your hand. Okay, over to you, Dr. Rukudzo. Anything else from the friendship bench?
Not a lot, but I would like to once again thank our partners, the Ministry of Health, for supporting us in all our projects and this particular project, and hoping that we'll continue working together with them to sustain this project and ensure that all healthcare workers get the service that they need. We've gotten the responses of how they would want to receive that service, and that will be taken into consideration. We'd also want to thank the WHO for their continued support in all the work we do. And mostly would like to thank our funder and partner, OPHID, through the funds from USAID and PEPFAR, who actually funded this project. And we hope that their pockets don't run dry, such that we are able to continue with the project, not only in the face of COVID, but as we continue with other programs. Healthcare workers are not only faced with crisis during things like COVID, but there's always a crisis or a pandemic around the corner, and they need that continued support. So we look forward to getting more funds from them so that the project continues. And I would like to appreciate the over 200 people who joined this meeting today and who have also given their feedback. We hope that you would reach out, not only because you have a problem, but number one, to try and also help our project such that it is better and we can improve it for you, for your colleagues, and for your loved ones. And I would also want to for you to reach out so that you can receive self-care materials, because we believe self-care is the cheapest thing that one can do for themselves. So we have materials that we have prepared. They are available physically, but we also have soft copy versions of these self-care journals and self-care materials that we continue putting together for our healthcare workers and the rest of the people that reach out to us. With those words, Tarisai, I would like to thank everyone who has joined. We've come to the end of our meeting, and we look forward to engaging with you again very soon. Thank you.